Good afternoon, everyone. I'm Tamiko Brown-Nagin, Dean of the Harvard Radcliffe Institute, and it is my pleasure to welcome all of you in person and online to Radcliffe's 2025 Gellert Family Science Symposium, which is made possible through the generosity of Catherine Gellert, a longtime friend and a champion of the Institute. Thank you, Kate. This annual convening invites leading figures in the sciences to share their expertise, ideas, and diverse perspectives with the Harvard community and the broader public. This year, our symposium will explore women's health from cutting-edge innovations to the historical and contemporary societal context in which they occur. A recent report by the National Academies of Sciences, Engineering, and Medicine makes a powerful case for additional support for women's health research. Yet the report's authors concede that the need for such support may not be self-evident. After all, the National Institutes of Health has a dedicated Office of Research on Women's Health, established some 3.5 decades ago, and women's life expectancy exceeds that of men. However, the authors write, clinical outcomes for women lag behind men, and although women live nearly 6 years longer than men, they live longer in poor health and with higher rates of disabilities. In short, the situation defies simple explanation. Advances in scientific research and clinical medicine have generated new tools for improved diagnosis and treatment of conditions that impact women's health. Research across the fields of genetics, molecular biology, epidemiology, and others is shedding new light on the complex biological and environmental factors that influence disease risk. And discoveries are moving from the lab bench to physicians' offices. For example, precision medicine, which seeks to shift care from a general to a tailored approach, is driving promising new innovations for clinical practice. Oncologists are already using molecular testing for some cancers to personalize care based on individuals' characteristics and their particular diagnoses. This includes testing patients' cancer cells to determine their specific qualities and select the most appropriate treatments. In some cases, genetic testing is used to identify inherited risk factors, such as the BRCA1 and 2 gene changes that increase the risk of developing breast, ovarian, and certain other cancers. These and other developments across research and practice hold exciting potential for the present and the future of women's health. Yet, as further research suggests, obstacles remain. Historically, women have been underrepresented in biomedical research studies. Indeed, until some 30 years ago, women of reproductive age were largely excluded from clinical trials in the United States. Though we've made significant progress since then, challenges persist, and they have important implications for medicine and for women's lives. Reports like the one I mentioned by the National Academies, as well as by the World Economic Forum and McKinsey Health Institute, have noted continuing underinvestment in research and gaps in data and scientific knowledge pertaining to women's health. Barriers to care, like cost and stigma, can further limit women's access to clinical prevention, diagnoses, and treatments. And among women, significant disparities in access and health comm have been identified along lines of socioeconomic status, race, geography, and many other factors. Our symposium today will consider both cutting-edge innovations in women's health and the societal backdrop against which diagnosis and treatment take place. We'll begin with a session on X-linked cancers, followed by a discussion about factors that differentially impact the course of women's lives. We'll then convene for our keynote session featuring Dr. Elizabeth Comen, a distinguished physician and best-selling author of All in Her Head, The Truth and Lies Early Medicine Taught Us About Women's Bodies and Why It Matters Today. After the keynote, our conference will conclude with the student poster session and ideas fair and a reception for everyone joining us in person. We welcome your questions throughout the program. Whether you're watching in person or online, you can submit questions using the Slido link that's provided on the screen behind me and posted in the chat feature of the Zoom webinar. This program is being recorded and will be posted on Radcliffe's website in about a week if you'd like to revisit any of our presentations and discussions you'll hear today. Now, before we begin our first session, let me express how grateful I am to today's distinguished group of speakers and moderators for joining us and for sharing their knowledge and expertise. Thank you so very much. Thank you again to the Gellert family and to the members of the Radcliffe Institute Leadership Society and all our annual donors. Your support keeps Radcliffe programming free and open to the public, and we thank you. I also want to thank Radcliffe Science Program faculty co-directors, Professor Immaculata DeVivo and Professor Ido Berger, for planning this convening in consultation with colleagues across the university. I'm grateful as well to Rebecca Wasserman, Executive Director of Academic Ventures and Engagement at Radcliffe, Jessica Vicklin, Director of Events, and their entire teams. And finally, thank you to everyone in our virtual and our in-person audiences for joining us. And now I'm pleased to kick off our first session, which will be moderated by my colleague, Glenn Cohen. Glenn is the James A. Atwood and Leslie Williams Professor of Law, Deputy Dean and Faculty Director of the Petrie-Flom Center for Health, Law Policy, Biotechnology, and Bioethics at Harvard Law School. A former Radcliffe Fellow, Glenn is one of the world's leading experts on the intersection of bioethics and the law, as well as health law. Please join me in warmly welcoming Glenn and our first speakers to the stage.
It's my pleasure to be here with everybody. And I want to just particularly acknowledge the Dean and the Dean's work to make Radcliffe the preeminent place at the university to have conversations we should be having, but we're often not having. And the ability to have this as a space for convening those kinds of conversations is incredibly important. My expertise is health law and bioethics, but just to be uncharacteristically modest, I'm not who you came to see, so I'm going to be extremely brief about this and just introduce the amazing panel we have today. We have Qingjiao Zhu, who is an Associate Dean for Research and Professor of Biostatistics and Data Science at the School of Public Health, LSU Health Science. We have Ursula Matulunis, Chief of the Division of Gynecologic Oncology and Brock Wilson Family Chair, Dana-Farber Cancer Institute, Professor of Medicine, Harvard Medical School. And joining us by Zoom, unfortunately someone came up at the last minute, but we're incredibly happy to have her, is Isabel Scaraggi, Professor of the University of Alabama at Birmingham School of Medicine and Senior Advisor for Global Cancer at UAB, O'Neill Comprehensive Cancer Center. Just to give you a sense of how this is going to go, they're each going to talk for a brief amount of time. We'll have a little bit of Q&A that I'm going to moderate, and then audience members are welcome to submit questions at any time during the session, and we'll get to as many of them as we can. Whether you're here in person or participating virtually, it's the same way to participate. You can submit questions using the Slido link provided on the screen behind me, and also post it in the chat room if you're virtual. So as I said, going to be brief, so there's more time for conversation, and I'm going to invite Qingjiao up to be the first speaker.
It's my honor to be a panelist here to present some of my work. I'm talking about gender breast cancer disparities. Let me tell you a story. It's not about one woman, but of many women. Let's imagine that there are two breast cancer patients who are diagnosed with breast cancer at the same time, but they come from very different background. One is from a well-resourced suburb where there are close top-tier hospitals. They have nutrition foods, they have clean air. The other woman comes from Cancer Valley. Let's imagine that in the Cancer Valley, it's a heavy industry area. There are polluted air, clinics are very far away, and their safety are uncertain. So they share the same diagnosis, but their journey and their outcome are vastly different. This is not a fiction. This is the health disparity exists widely and very persistently. Can I have the next page?
We've got the slider here.
Oh, okay, thank you. So the cancer disparities exist in mortality. We find that in incidence. There are some ethnic and racial populations that have higher incidence of breast cancer, and they're more likely to get more aggressive cancers. This disparity also exists in progression. There are cancer patients who are diagnosed with later stage breast cancer, and there are patients who have cancer that developed very fast. And the disparity exists in survival, where this 5-year survival rate, the recurrent rate, and also the health-related quality of life vastly different. For example, that we find that African Americans have a 40% higher mortality rate in breast cancer compared with white patients, although their incidence rate is 5% lower. And also we find Hispanic population have a higher probability of diagnosed with later stage cancers. Also, Native Alaska and American Indians have a higher 6% higher mortality rate compared with white patients. There are a lot of integrated influential factors, including individual behavior, like smoking, physical activities, alcohol use, and there are genetic factors that people might have variant genes. And there are social determinants impact, factors like income, education, housing, and healthcare access. All those heavily influence the breast cancer outcome. And environmental factors like air pollutions, water pollutions, exposure to chemicals, those all exacerbate the health disparity. Even the neighborhood effect, crime rate, and access to safety place for physical activities all have contributed to the breast cancer disparities. Moreover, limited screening access and underrepresentation of certain population in clinical trials have contributed to the delay of diagnosis and worsened prognosis. There are innovative biological and epidemiological studies. Biological researchers has used tumor tissues and animal models to identify molecular biomarkers that underlying the functional pathways can explain the tumor progresses and disparities. The animal models and patient-derived xenografts have been instrumental to help people to find out the disparities, the mechanism underlying the disparities. And also, statisticians and epidemiologists has integrated individual behaviors and genetic data with environmental data, and we developed advanced statistical models trying to isolate effect from individual effects, social determinants, and environmental factors on the cancer outcomes. Also, there are geospatial analysis. There are machine learning methods. There are population simulation studies that help to identify regions with high risk of breast cancer and low screening rates. So geospatial method has been helped to guide the resource relocation and intervention strategies. For example, mobile mammography were introduced to low underserved areas to help to promote equitable cancer care. And artificial intelligence has been a great tool to help to improve predictions and to help design personalized treatment and help to inform and guide the decision for the patient to develop their decision making and help them with to offset the mental and emotional and financial burdens. So overall, there are persistent health disparities exist in the field, in the breast cancer treatment, but there are also biological and epidemiological studies that help to improve the health outcomes. And we have developed AI tools to help to improve the health disparity, find out the mechanism underlying the disparity and to improve the health disparity. So that's pretty much.
Thank you very much. Big round of applause. And Ursula, I'm going to turn it over to you next.
All right, welcome everybody. It's great to see everyone on this beautiful day. So I'm Ursula Matalonis. I'm a medical oncologist at Dana-Farber, and I run our division of gynecologic oncology. And it's a real privilege to be here, and thank you for inviting me. So there's been significant treatment progress for advanced GYN cancers, and this is what I do every day. I see patients a day and a half a week, and then run our division and help run our clinical trials. And as the dean astutely observed before, that improved understanding of tumor genetics and therapeutic vulnerabilities, as well as now access to both germline and somatic or tumor testing, have really led to new treatments for our patients. And these are some examples. The PARP inhibitors, these are drugs that interfere with DNA damage and repair, have improved outcomes for our patients with advanced BRCA-mutated ovarian cancer. Immunotherapy, those ads you see on TV for checkpoint inhibitors, added to upfront advanced cervical cancer treatment, as well as mismatch repair deficient endometrial cancer, have improved survival. More recently, there's been an explosion of drugs called antibody-drug conjugates, and the drug mirvetuximab soravtansine, which targets folate receptor alpha on the external portion of the cancer cell, has led to improved survival, as well as other outcomes such as response rate, et cetera, for folate receptor alpha ovarian cancer patients. And lastly, most recently, in a rare subtype of ovarian cancer called low-grade serous ovarian cancer, specifically RAS-mutated low-grade serous ovarian cancer, there's been a doublet of a RAS-MEK clamp, along with defactinib, which is a FAK inhibitor, that's really improved outcomes. So there's a lot going on. However, there are also challenges. There's really unique epidemiology of all the gynecologic cancers. For endometrial cancer, there's been a rising incidence, worsening survival, and an increase right before our eyes of increasing kind of poorly behaving and biologically more aggressive types of uterine cancer, serous carcinoma, carcinosarcoma, and clear cell cancers. So we've really had to steer our therapies towards these tumors. For ovarian cancer, yes, which has been great, survival was improved, and our prevalence is increasing. Rates of this cancer are also dropping, but there's still no early detection test, and most of our patients are diagnosed at advanced stage. And each histology has its own unique genetics. For cervix cancer, despite the HPV vaccine, not all eligible individuals will get this vaccine, namely about 40%, and we're seeing the incidence increasing again. Clinical trials, which we're going to talk about today, really can take years to develop a new drug takes a while to get a new clinical trial off the ground. And for example, PARP inhibitors, we first started our first randomized phase 2 of these drugs back in 2008. Initial FDA approval came in 2014 for mirvetuximab soravtansine. We started phase 1 trials at the Harvard 2012. Didn't get initial accelerated approval until 2022, full approval in 2024. Trials are expensive. There's increasing regulatory burdens associated with them. We need new ideas. New ideas are generated by laboratories, basic science laboratories, people like us getting together to talk about different things. COVID set us back, and obviously funding issues exist currently. And speaking about funding, this is taken from the cancer.gov website that shows you the cervical cancer, ovary cancer, and uterine cancer funding. 2023 is all on the right. You can see over time what happens. And uterine cancer, despite a cancer that has a worsening survival over the past really 4 decades, only $20 million has been allotted to this. So important to make sure that we write grants, and we are really asking our federal government to give us funds. So what does our Division of Gynecologic Oncology do? We have a pretty vast research staff who helps us run our clinical trials. It's about 30 individuals, including data managers, regulatory specialists, research nurses, et cetera. We run trials all the way from phase 1 to phase 3 for all GYN cancers. We also have quality of life cancers. And importantly, we have a tissue banking effort as well. And this tissue bank collects fresh tumor samples, either cancer samples from the operating room or ascites fluid, which is fluid that can accumulate in the abdomen when a cancer becomes more advanced. And these samples are disseminated to our basic scientists and to others to help formulate these new ideas. We write grants. We currently have a program project grant in hard-to-treat uterine cancers, specifically on replication stress. We write other NCI grants, and also with a focus on early career investigators. And obviously, we also, importantly, focus on great patient care. And I just want to finish off with an example of what really drives me to come to work every day, besides working with wonderful colleagues and junior colleagues. This happened last week. It's a 55-year-old patient of mine with platinum-resistant ovarian cancer who's currently on an experimental antibody-drug conjugate. She's quite symptomatic with intra-abdominal tumor burden, has a lot of abdominal distension. She'd been treated with 3 prior lines of treatment, and without a clinical trial option, standard chemotherapy would have less than a 10% response rate. But what's happened with this drug is that on the left, you can see prior to the experimental treatment, there's fluid that's sitting underneath. I don't know if I can show you on this, probably can't, but underneath the liver. And then just after 6 weeks of treatment, just 2 cycles, she was symptomatically better. She did not require a paracentesis to remove fluid. She felt like herself again, and her CA-125, which is a marker of ovarian cancer progression, dropped from 320 down to 34. So this is what really drives all of us to keep doing what we're doing. And I'm going to finish up right there. So thank you so much, and happy to take questions.
Thank you, Ursula. Now we're going to switch to the Zoom for Isabel. Hopefully we can get that working.
Yes.
There we go.
Hear me?
Yeah.
Very well. Thank you for joining us.
Okay. Great. So thank you so much for the invitation to speak to you today, and Becky and the team being so kind and understanding when I related the news that I would not be able to be there in person. So I really appreciate, because I was looking forward to being with all of you today and being back at Harvard when where I was almost 30 years ago. So as you have heard from Doctors Yu and Matlonis, we have come a long way in the advances in prevention, early detection, and treatment of gynecological cancers. Still have a long way to go, as Dr. Matlonis mentioned, but there's only one cancer, only one gynecological cancer that can be eliminated, and that is cervical cancer. the discovery that HPV infection is the main cause of cervical cancer has really opened the doors for great technologies that gave us the hope of elimination. HPV vaccine to prevent HPV infection, age-appropriate screening now, instead of the old cytology, we have HPV testing that detects the presence of the virus much earlier before cytology changes, and great tools for follow-up in treatment in the event of abnormal cervical cancer screening results. I'm a behavioral scientist, and I spent my entire career developing, implementing, and evaluating evidence-based strategies to get these tools to populations experiencing high burden of disease, particularly in the rural US South, where I am, in Alabama and Mississippi, and low middle income countries. And really in a reciprocal way, we start here, sometimes improve our strategies in low middle income countries and bring it back to rural settings in the US and vice versa. Also, I have been very fortunate to be involved in the development of some of these tools, make them acceptable and viable from the inception. Because a lot of times we do not involve behavioral scientists in the early development of these tools. And then women they're not really acceptable or viable. We are one of the first groups in the US to explore self-sampling for HPV testing as a screening alternative for women who are reluctant to or do not have access to healthcare where they can collect their own sampling at home. We can discuss this under the questions, but it has taken 20 years. This was 20 years ago when we started, and we just got approved by the FDA and to be used in clinical settings when the real use of this technology are in the community. But I think we're very close of getting approval to be used in the community. So me and others, many others have done the studies. We published, put the publication on the shelf. We know what works. We have the evidence-based tools that are free in the US, either covered by health insurance or federal programs like the CDC breast and cervical cancer screening early detection program, vaccines for children. The World Health Organization has launched an elimination plan. So why do we still have high cervical cancer incidence and mortality in the US? What Dr. Matulonis mentioned, the increase in cervical cancer at Mass General or in Boston, it's even worse in Alabama. Our fellows see a cervical cancer here almost every week. And that's when we decided to do something else, even beyond implementation science. We decided to engage civil society based on a great model that has proven to work, that is polio eradication in the world. So along with the Alabama Department of Public Health, because government is very important in this piece, the Rotary Club of Birmingham, given the very strong presence of Rotary clubs in Alabama, as well as the world and other partners, we put together a plan to eliminate cervical cancer as a public health in Alabama. That was officially launched by our state health officer in 2003. It focused on 3 pillars: HPV vaccination, screening, and follow-up. And Alabama continues to be the only state in the United States with an official plan to eliminate cervical cancer that engages civil society and engage a lot of partners. It's called Operation Wipeout. You can go to www.operationwipeout.org to learn more about it. It has been an amazing initiative. and I can address the specifics during the questions and answers. But we have increased vaccination. We worked, one of the highlights for me is working with high school students in a rural county with very high incidence of cervical cancer, the highest in the state, as high as Alabama, as Guatemala or Nicaragua. And they developed an HPV vaccination campaign and got 81% vaccination in one of the high schools and 67% on the other. And now they're working with middle schools. The adherence to follow up is a big problem because women get screened and then they need to travel to Birmingham or travel to Montgomery for follow-up. So the Alabama Department of Public Health trained traveling nurse colposcopists who go and do the follow-up where women were screened, and has been a game changer. And I have many other examples, and partners keep coming in. And I think more important that I want to share with the group, it's not a grant, it's not led by one organization, and there's no money. So everybody who comes we ask, what can you do? And that's how we have been able in such a short period of time do so much in Alabama. Thank you.
Thank you very much. Keep the Slido questions coming. I'm getting the list, but I'll start with a few questions of my own. And this is really to anybody who wants to answer, all of you. I'll ask you specific questions about your work, but imagine we were having this conversation not in this august room, but you were addressing the freshman college women of Harvard and the next generation of women who are facing these issues. What would you tell them? What would you direct them about the work that you're doing?
I can start. I think that's an interesting question. I think there are challenges in a lot of different things, but on the other hand, it's very exciting. And I think, and I always, when I counsel residents or even medical students, I really advise them to try to figure out what really they're going to be super interested in and really aim towards that. Obviously careers and the work that we do changes over time, and mine certainly has for certain over the past several decades. But obviously you got to work hard, you got to show up, and pick fields and problems that maybe people are not working on, but that you find exceedingly interesting and that you can really become a leader in. And again, that drives your interest and desire to come to work every day.
Great. Okay, I'll jump into some more specific questions then. Jing Zhao, if I could start with you. I guess I'm curious, so one of the things that's so interesting about your work is some of the disparities we find are not necessarily what one would expect given priors about how disparities manifest and the like. You had the ear of policymakers and you could say, here's the research I've done on these disparities, here's what needs to be done, or here's where more attention needs to be paid. What would you have policymakers focus on?
So there are a lot of factors related with this health disparity, especially social determinants, like there are underserved areas that people don't get prevention very often, and they don't have regular screening. And I would want the policy be changed in different ways. Like we can develop mobile mammography to help people to go to the patients directly to get their regular screening. And also paired with that, we need to have training and education system to help people know the importance to have screening. And also insurance has to be improved so that everybody can have access to the care without have to worry about that what will happen if we go to the screening, what I need to pay. And also, I think AI tools should be developed to help to educate people, help with scheduling, to remind people to go for screening, and also to provide interpretation of diagnosis, help with information, and also help with decision making. So I think people need to be educated to how to use different tools, and everybody should have the information, the correct information to help them to prevent cancer, to have cancer screened. They need to have access to the prevention programs. I think that's the focus that we should work on.
Thank you. Ursula, you spoke a little bit about some of the obstacles to success in the space in clinical trials, and obviously we're having this conversation in the middle of a government shutdown after unprecedented gutting of NIH funding. But I guess I wanted to ask you, beyond funding, you mentioned a little bit about the FDA review, the clinical trial design, recruitment. What do you view as the biggest obstacles for getting clinical trials to show success and to be successful and to really move quickly?
I think that's a great question, and I think there are multiple different components to that question and the answer to that question. I think certainly asking a good question, having appropriate objectives for the trial, and really making it a meaningful question that you're going to answer. As clinical trials, the ideas get launched, the trial gets written, it gets launched, and it finally opens up. Standard of care can change, and we see that happen all the time. So it really is up to the principal investigator of the study, the team, to allow standard of care changes to be incorporated. And sometimes the clinical trial just doesn't make any sense anymore. That doesn't happen often, but sometimes it does. So then you just say, well, let's focus, put our efforts on something else. But it's really important to try to make sure that that question is appropriate, and that at the end of it, you're going to have an answer to improve the lives of future patients by the question and by the way that you've done the trial, to make sure that there are not that many deviations or exceptions made to entering into the trial. So I think those are very important facts.
Thank you. Isabel, I'll show my bias as a northerner that if you'd asked me, pick the state that has the most successful plan to eradicate HPV, I don't know that I would have jumped to Alabama, but I'm delighted, and I'm delighted at the work you've done. But I wanted to invite you just to say a little bit more about the engagement of civil society and individuals in this, especially at a time where vaccination is not perhaps as easy a sell public policy-wise as it has been historically. How you overcome resistance, how you overcome kind of concerns, and what has led to the success.
Well, I think sometimes when we are a poor state, we come together and to solve a problem. So I want to start with, so a lot of us in healthcare, we spend a career talking to other healthcare providers, healthcare, public health, and we all talk the same language, we all understand each other. And really, I think to me, the success of Operation Wipeout is when you go out and talk to lawyers or business leaders, or you have, any walk of life, and give the message that there is one cancer that can be eliminated. And they get it. That has been our success, and that is Rotary. So we engaging Rotary clubs across the state, and now really across the world, what we are doing, it has been fascinating because the Rotary members are the leaders in those communities. They are the ones that they look for advice. Because I don't know in Massachusetts, but in Alabama, trust in healthcare system, my data shows and my experience shows that more and more people do not trust the healthcare system, but they trust that business leader. They trust the owner of that store that they go for, their baking goods or what have you. So that is this, to me, the success. And Rotary for us has been a great platform, because if we eradicate, in this case, polio in the world, was Rotary that engaged around the world in 1985. And look at where we are today. We only have Afghanistan and Pakistan. So I had polio, and I grew up going with my mother door to door, vaccinating children. And then I spent my life doing that. So I think that is the success. I think the other success is what I mentioned, is not that we have one organization with, $10 million to do the campaign. Everybody owns everything that's in our website. All the evidence-based materials belong to everybody. Anybody can copy them. Anybody can use them. And that, I think, has been really, for us, a major success. The other thing is to have a brave state health officer that launched the campaign. Because if we had launched, or Rotary had launched, there were no teeth. But when a state health officer launches the plan and stands by the plan, that made a big difference. But the other thing we do in this, as you mentioned, we focus on elimination. So if I go to a more conservative Rotary Club and I get some pushback on the vaccination, I say, you can do screening. If we have a high incidence or mortality today in the United States, it's not because of lack of vaccination. We're going to see that in about 10, 15 years. It's because of lack of screening and follow-up. So you keep the dialogue to elimination, and do not engage in the discussion of, for or against the vaccine. Even when we educate the high school students or other champions across the state, we say, the point is not to be on anybody's face that they need to get the vaccine. We say, you are the parent. You know what's best for your children. We are just providing the education. And I do not engage in any political discussion. I always punt. Who doesn't want to eliminate a cancer? So there is no political lines there. So that has been our success. And to be honest, we never got any pushback. This school system, for a superintendent to step up and say, you can train our kids, open the doors for a school, and he never got an email or a phone call from a parent, and neither has our state health officer.
That's great. Xingjiao, I wanted to ask you about artificial intelligence. You mentioned a couple of times the machine learning in this space. Do you have a sense, or could you give us a preview of where you think its deployment would be most successful? Are there things about it you're excited about? Are there things about it that worry you in this space?
So for AI, tools has been developed. I think it is mainly used. One of the area is that AI can use the large data set and find out a pattern out of it. They can improve the prediction, and they can help design personal treatment for individual patients. This is one part. And the other part is that AI can help to improve the communication. We now are we don't have enough nurses, physicians that help to interpret the diagnosis, to guide the patients and the caregivers for every step of their journey in the cancer. But telehealth and communications using the AI, they can help to provide information and also to help with decision making, to schedule the appointment for patients to remind people of prevention screening cares. I think that's another part that AI can help with communication, to give information and to help guide with decision makings.
Thank you. Ursula, I wanted to invite you to imagine you were able to sit with the FDA commissioner at the moment and say, listen, the kind of trials and the kind of drugs and the kind of interventions I work on are different in some ways, and I would love to, have some sensitivity and some recognition of that. Are there pivot points that you wish or you could influence FDA that might be changes in the way they think about this?
Another good question. I think that the FDA and the NCI are changing how, and I think this is important, and I don't think we do this well. And I mentioned some of the kind of obstacles for clinical trial, and that's really when you've got the clinical trial written and you're launching it. But what happens before the study starts, and how we develop an idea, and how do you decide that two drugs should be brought together? How should you design that study? In what preclinical, so preclinical means before the drugs get placed into a human being from a phase 1 standpoint, what evidence should we provide that substantiates that this is a good idea? And I think there's been a movement now over the past several weeks to months away from the use of animal models, and away from the way I was using for cheers, and more towards models that are from the human being, such as organoid models and maybe cellular culture models. And I think we're going to see how that works out. I think there's probably still some with the patient-derived xenograft models, which basically take cancer cells and their heterogeneity, put that into an animal, and then replicate the human cancer in an animal. That is one idea. But then taking the cancer from the human being, growing it in a ball, in an organoid, that maybe even has some immune cells to replicate the cancer there. So I actually would look forward to working with the FDA, and all of us in oncology, working with the FDA to come up with some certainly, I think, rational guidelines about what is really needed to, again, really substantiate that clinical trial moving from preclinical models into a human being and make sure that it's safe as possible.
Great. So we've got a ton of great questions. Please keep them coming. I'm going to start shifting us now to some of the Q&A from the audience. One question we've gotten is about trend lines and whether you have any thought about what is responsible for different trends we're seeing in different kinds of cancers, X-linked cancers in particular, and whether you have views about what the causes are, maybe also what some of the social determinants or environmental solutions might be. And anybody who wants to answer, please jump right in. That's what I call voluntold. Go ahead.
And I'll answer it after you.
So the trend in the women cancer, I think it's that we're detecting cancers at early stages and to focus more on the prevention instead of at the end stage of the cancer. So, and also we're trying to improve the quality of life for the patients. So the trend, generally, the trend is that cancer are more and more diagnosed at early stages, and cancer are diagnosed with curable trend. The mortality rate, we expect them to reduce, and everybody can have free prevention screening, have access to either through the telehealth or go to the clinic in person to get cared.
So I think from a GYN cancer standpoint, as I mentioned, the good news was that ovarian cancer rates are declining, survival is improving. I think the survival improving is because we know how to take care of patients better. There's an increased use of neoadjuvant chemotherapy for those patients who are just unable to go to upfront surgery. So that has made an impact how we just supportive care. Why the rates are decreasing? I think one possibility is that the use of estrogen therapy, progesterone therapy as postmenopausal treatment has lessened, and that's a good thing. For uterine cancer, there's really a disturbing trend going up for, as I mentioned, these higher risk types of uterine cancers, serous cancer, carcinosarcoma, clear cell. I remember when I started my career, we barely saw serous carcinomas, and now they're really quite common, and the numbers support these trends. Again, overall uterine cancer has gone up, and that may be to just the increased obesity of our population, and it may not just be, it may be different levels, but I don't think the explanation has been really teased out well at this point.
We got a cluster of questions that I might just put in like the ethics bucket here, in particular relating to telemedicine, relating to remote monitoring of patients, and also relating to AI. And I guess some of the audience members are curious whether you all think that people should be worried about this sort of stuff when it comes to X-linked cancers and the like, and the data collection and the like.
Should be worried about telemedicine or?
Telemedicine, remote monitoring, where the data goes, who has access to it. These are the kinds of questions I guess some of the audience members have.
No, I think that's very reasonable. I think, for at least that where we are at Dana-Farber, patients sign a consent. So you understand if tissue is being collected from you, from the operating room, et cetera, where exactly that tissue is going. And we do everything anonymized. So if tissue gets sent to a lab that's down the hallway, it just has a number, it doesn't have any names, and that laboratory investigator cannot have access to those names. So we are very, very strict about that. I think from telemedicine standpoint, I think telemedicine has been a really incredibly good thing. There's really a lot to be said about seeing somebody in person, examining them, talking to them face to face. But if there's somebody who's 4 hours away in northern Maine or upstate New York, and I just need to tell them scan results or just check in with them, it's a lot easier for that individual, for me to communicate that information via telemedicine, either a virtual visit through a Zoom or through a phone visit. So I think that has really improved just quality of life for patients, knowing that they can always come in and see us. But for signing consents, obviously getting drug treatment, they need to come in for that.
I think in the AI area, the ethic is a growing concern for people that we have big data sets and the security of the data, and also the accuracy of like AI predicted results and information. Those are all the areas that needs to be accompanied to improve for the AI technology development. We need to help patients to know how to ask right questions and how to identify whether the information provided by AI is correct or not. And also how to use the information from patients to help to improve the diagnosis and treatment without leaking patient privacies. Those are all ethic areas that needs to get more research on.
Great. Isabel, I think this question's mostly for you. We had some interest in the role of men as partners in spreading HPV and screening projects, and whether screening of men is helpful at all, or just in general the role in what you've rolled out in Alabama of the male side of it. And if you have anything to say about that, that'd be great.
Yes, and we get asked that question a lot. Why we are focusing on cervical cancer when HPV causes that we know of for sure 6 cancers. Oropharyngeal cancer is way on the rise among men, and we expect that they will surpass women in a couple of years because it's growing very, very fast. And then we have penile cancer and anal cancer in men. So when we educate, we do talk about the extra benefits of the vaccine. But our decision to focus on elimination of cervical cancer, because it is the only one we can talk about that. We do not know as well the natural history of the others. And also, we really do not have screening as we do for cervical cancer. You can see, the dentists now are well trained to look for lesions in terms of oropharyngeal. So there's a lot of studies coming that especially anal cancer, where we know a little more about natural history, but we cannot talk about elimination, and we have vaccination, but we do not have good screening as we have for cervical. So our approach is we educate. That's why the vaccine is also for men and the prevention of all the other cancers. But also we try as much as we can to have men in front of audiences. So, because it's not only, I think that's the other thing about Operation Wipeout that we were very careful about, that it's not only looking at our belly button and say, gosh, I'm screened now, or my kids are vaccinated, this doesn't pertain to me. And so the more we put men and everybody in front of people to say, no, it's about really getting on this and making, accomplishing the mission of eliminating a cancer. And I think that's what has helped us, because it's a positive message. And I think that once we get that, get that going, what we have seen is they come and then we talk about cervical, and then they say, oh gosh, I haven't had my mammogram or colorectal. So it's opening doors for people to talk more about it, including, like, we work some with rural volunteer firemen, fire places, because in rural Alabama, they're mostly volunteer. So to have that presence, but with the positive message, and then we have the benefits of, if they get vaccinated, to prevent the other cancers.
Great. Xingjiao, I think this is mostly for you. A question on pollutants and the focus on genetics over environmental factors, and how to think about the role of carcinogens in the work you do.
So in one of my work, we're trying to find out environmental risk factors that is related with different gene expressions that will have an influence on the health, the cancer outcome. I think we want to identify mechanism underlying how environmental, like chemical factors, how the pollution from the air, how the PM 2.5 can influence the expression of genes, and how those can influence the result, the healthcare result. So we want to find out the mechanism and then find out treatment that can target to the mechanism and try to improve the health accordingly. We have identified, for example, live close to the airport. There are noises. There are also airplane released chemicals that are related with higher cancer incidence. And how can we help people live close to airport to release the influence we need to first know what are the mechanisms that influences the cancer incidence, and then we can work on that. So I think the main thing we want to do is that find out what is underlying the association between proxy to airport relate with the airport with cancer outcomes, and then we design methods prevention and to prevent and to treat cancer patients. So I think that's probably the direction. Did I answer the question?
Very well. Ursula, did you want to jump in too? Is it you? I saw you leaning forward.
No.
Okay,
no,
I've got a question for
no,
you.
I'm
If you
gonna,
didn't.
I don't. I think. Yeah. I don't.
Okay.
I don't
I've got a question for you. It's
really
okay.
yeah.
One of the questions from the audience has to do with patient involvement in study design, in particular clinical endpoints, but other elements of study design in your space and how you involve patients or what role there is for patients in this process.
I think it's really, really important. It's a great question. For example, we're planning resubmission of a large federal grant called the SPORE grant, Specialized Program of Research Excellence. We have two, one in ovarian cancer, one in endometrial cancer, and it's a cross-Harvard collaboration. But each of those grants have at least 3 or 4 patient advocates on it. And I lead the ovary SPORE grant, and we just had sessions over the summer where we basically took 8 projects and distilled them to 4 to present to our external advisory board, so people around the country who advise us on our grant. And the patient advocates were absolutely critical to helping us really decide which projects we should do or not. And I think that's really very important. And we just need to continue to do more of it, but it's critical.
Great. So this was now for all of you. Someone wants to know if you were put in charge of a national women's cancer plan and you had the president's ear and had all the agencies involved, and you had the opportunity to kind of give your list of top bullet points to focus on, what would you advise?
I would ask the president to give out a rule that regular screening for different kind of cancers should be implemented. People have to be given the opportunity and be educated about the importance of cancer screening. And I hope the president can support this education and to make this screening program to be available to everyone in the States.
So I would vote to increase funding to women's cancers, period. I think, and it was on that graph I showed you, or that table I showed you, rates have been very stable for women's cancers. Uterine cancer, just $20 million per year for a very vastly underfunded cancer, and the other tumors as well, cervix, ovary, breast, et cetera. I would also increase funding for prevention and early detection. I think that is really, that's crucial as well. And I think, something that I was mentioning before as well, of kind of the designing of rational clinical trials. We're getting more and more medications, we're getting more and more targets, and how does that synthesize together to come up with rational clinical trial designs that really is benefiting all patients, and not necessarily just the larger numbers of cancers like colon and lung, but also the other cancers such as the gynecologic cancers and other more rare tumor subtypes.
So,
Please.
I'm with Urs. I think we need more funding. It's in women's health, and not only cancer. But really, I think the more we need to think about this integrated model because even when we work in rural or underserved areas, I go with cancer, the next day somebody who goes with diabetes, educate about diabetes, the next day is maternal deserts. And we need to strengthen of Office of Women's Health, because then if we really think of women's health beyond reproductive health, we're going to strengthen cancer, and we're going to strengthen diabetes, and we're going to strengthen cardiovascular. It's just that for women in particular, being this segmented cancer, diabetes, cardiovascular, and from the lens of reproductive health, I think that is what has stalled us some. So we really need to think of integrated women's health. That would be my advice.
I agree with you. It's a great idea. Yeah, of course.
And this will probably be our last question, so there's a facet for each of you. And it goes really under, I put a few questions together about diversity, but also about intersectionality. And so I guess for you, I'm curious about the use of people are curious about the use of biostatistics techniques to try to tease out the role of disparities and what is causing disparities. For Ursula, the question is about clinical trial design and inclusion criteria and how to have more diverse populations. And for Isabel, it's about the needs to have kinds of communications that are sensitive to the needs of very diverse communities and how you manage that. So with the time remaining, I'll let you each take an answer to that.
So I think that from biostatistics point of view, that we want to integrate information from individual behaviors, from inherent genetic factors, and also from environmental factors, social determinants. And we want to develop multi-level models that can build all those risk factors into the modeling and to isolate the effect from different pathways, so that we can design policies, we can design personalized individual care plans for patients, that we can improve the health and reduce the health disparities. So causal inferences, mediation analysis, and use of high technologies to improve predictions, that will be the focus for the biostats area of research.
So I would say that really two lines of statements. One is to increase the understanding of biology of diverse populations, and we are really trying to collect tumor samples from patients of different demographic, ethnic, racial backgrounds, and make sure that they are in our translational platforms, that we're really not excluding anybody. And then secondly, in terms of access to clinical trials, making the education of a clinical trial less frightening, more understandable. So it's open to everyone, and they think about it equally. And then also make it easier for patients to enter into a clinical trial from a financial standpoint. I did a podcast a few months ago with a researcher from Cornell who basically suggested that we should pay patients who are under-resourced, so that they can pay bills, pay transportation costs, family costs, to enter onto a clinical trial. So think of these kind of outside-the-box ways of improving access to clinical trials.
Isabel, you get the last word.
Yes, so I have worked in cancer disparities, especially racial, ethnic, and rural, my entire career in the South. And so we did a study a few years ago in the southern states and Puerto Rico, and looking at barriers, the typical barriers and facilitators to participate in non-therapeutic trials. And we focus on Latinos and African Americans. And the main reason was they were never asked. So I think that was one of my frustrations, and is in my own institution, is that we focus sometimes so much on educating the community, educating that they need to participate, they are welcome. but once they get to our institutions, we have ill-prepared staff or even providers who they don't feel welcome. So I do think that for us to really increase, we also need to look at, what are we doing? And are we prepared? Are we preparing our fellows, our residents, our staff to receive this population? And without, the biases are astonishing. Because I have a colleague who is a physicist from NASA, but because he retired in a rural county in Alabama, he had multiple myeloma. I'm sure he will be happy to share his example. They immediately assumed that he didn't have resources or didn't have access because he chose to retire in a very rural area. So we really need to think of our biases from the healthcare system to really promote inclusion. Of course, the trust is a big issue, and we need to increase, trust. And this is for somebody that spent 30 years in health disparities and doing tailored intervention to Latinos and African Americans. Today, after doing that, and you can see all my publications, are we really tailoring, or are we understand? Doesn't matter, we just need to understand where they are coming from and try to see the world from their perspective, no matter who they are. Those are things I think that us as providers, us as researchers need to really think about. Because a lot of our discourse is they. The problem is them. No, I think a lot of the problems is us.
That's a great place to end. Please join me in thanking this panel.
Thank you, Glenn. I'm Immaculata DeVivo, the Melanie Nemec faculty co-director of the Life Sciences, and I want to thank the panelists for sharing and contributing all that wealth of knowledge. I want to say that even though each person shared their specific area, what came very clear was the power of positive engagement, engaging with community, engagement with patients for clinical trials, and engagement with communities with respect to screening, AI tools, and education. So with that, I want to remind everyone, we're going to take a short break. We'll be promptly back at 2:30 for those in-house as well as on Zoom. Thank you.